We're now moving into the second half of this symposium. My name is Patricia Brubaker. I'm a professor emerita in the departments of physiology and medicine at the University of Toronto. So I'd like to thank Dr. John Dirks for asking me to co-chair this session. Okay, and my task today is to introduce our next two speakers. So I'm absolutely delighted to introduce the first of those two speakers, Dr. Daniel Drucker. So I'm not going to go through his bio, but Dan is a clinician scientist at the Lunenfeld Research Institute and professor at the University of Toronto. His pioneering work as a postdoctoral fellow in Joel Habner's lab in the late 1980s led to the discovery of the gut hormone glucagon-like peptide 1, GLP-1, as a potent and safe stimulator of insulin secretion from the pancreatic beta cells. And I'll just parenthetically add that at that time, when Dan and I went to present our results or our studies on GLP-1 at conferences, the only people in the audience were the two of us. I went to his talks, he came to my talks, and sometimes a few very kind friends would attend as well. And there was, no one had any idea at that time what a global phenomenon GLP-1 would in fact become, with millions of people now worldwide with diabetes, type 2 diabetes or obesity treated with GLP-1 receptor agonists. So over the past 3 decades, Dr. Drucker has continued to make seminal contributions to our understanding of GLP-1 and its actions. And for these studies, he's received multiple awards, both nationally and internationally. So because you're here to hear him and not me, I'm going to turn the floor over virtually to Dr. Daniel Drucker to present his talk entitled Beyond Diabetes, GLP-1 is Changing Outcomes for People with Cardiometabolic Diseases.
Hi there. My name's Daniel Drucker, and I'm delighted to participate in this very special symposium at the University of Toronto, and thank you very much to the organizing committee. So my topic is GLP-1, and I do have some disclosures which we can highlight here. I have worked with some companies, and some of these entities do support work in my lab. So in today's vernacular, this slide would be described as how it started. You know, in the 1980s, we had the glucagon gene sequence. We found these glucagon-like peptide sequences within the gene. We didn't know where they were made or what they were doing. And these were some of the experiments I did in the Habner lab in the mid-1980s. And one can see here in islet cells, there is an increase in cyclic AMP, an increase in insulin gene expression, and an increase in insulin secretion. And very importantly, this only happened when we used the truncated GLP-1 peptide, and it only happened when we increased the glucose level. And of course, more than 35 years later, today we can say, well, how's it going? And we all know that there have been tremendous developments in this area with multiple new agents, really getting better and better with the introduction of each new entity, from twice a day to once a day to once weekly, and perhaps very soon even once monthly. So how has GLP-1 therapeutics caught our attention? Certainly beyond diabetes, there's the weight loss story for people living with obesity, and that's extremely exciting. We also see here in the slide that GLP-1 has many actions beyond simply control of glucose and body weight. And thankfully, most of these actions are indeed favorable for people at risk for developing the complications of metabolic disease. Now, no medicine is without adverse events, and GLP-1 receptor agonists certainly do cause adverse events, summarized here, predominantly gastrointestinal. Thankfully, most of these events do go away in most people after a few days to weeks. Not everybody can take these medicines. There are some people that just don't feel well, and they decide the medicines are not for them. You notice acute kidney injuries at the bottom. It's rare, and it's not a direct toxic effect of GLP-1 in the kidney. It's really those people with tremendous nausea, vomiting, dehydration that put themselves at risk for acute kidney injury due to the dehydration. It's always important to have the discussion. Please make sure people still maintain hydration. So as we know, the Food and Drug Administration in the era around 2010, 2012 said we need to assess the cardiovascular safety of all new diabetes drugs. And we knew that GLP-1 produced the following favorable changes in cardiovascular risk factors, but there was also this increase in heart rate that made some of us a bit nervous. And so we waited with some interest and anxiety for the results of the cardiovascular outcome trials in people with type 2 diabetes. And summarized here are 8 cardiovascular outcome trials with different GLP-1 receptor agonists. And you can now, I think, safely conclude that this is a class effect, that GLP-1 is not only safe, but it's also helpful in reducing non-fatal myocardial infarction, non-fatal stroke, as well as a reduction in cardiovascular mortality and all-cause mortality. And that's provided a tremendous, I think, foundation for ongoing use of these medicines in new indications. Now, we also had the introduction of SGLT2 inhibitors, tremendously important advance in cardiometabolic medicine. And there's a few differences, and one of them is shown here. SGLT2 inhibitors don't reduce the risk of stroke. GLP-1 receptor agonists do. SGLT2 inhibitors are better for heart failure with reduced ejection fraction, and clearly better for people with kidney impairment. So we have 2 medical classes now, I think, that we can favorably use to reduce the complications of diabetes. So how does this happen? For SGLT2 inhibitors, we still don't really know. For GLP-1 receptor agonists, I think we still don't really know. Some people say, well, you're just improving glucose control and reducing body weight. But we can see some of the trials as shown here. The Harmony outcome trial with albiglutide, a once-weekly GLP-1 medicine withdrawn from the market because it was so commercially unsuccessful, because its ability to reduce glucose and body weight were so modest, it just couldn't compete. Yet in the cardiovascular outcome trial, which had a very small reduction in A1C and less than 1% reduction in body weight, there was still a 22% reduction in MACE driven by a reduction in heart attack. So this mechanism really can't all be secondary to glucose and body weight. And we and others have studied this, and we use model organisms like mice to try and tease out where are the GLP-1 receptors and are they critically important for cardioprotection. In the mouse heart, the receptors are in the sinoatrial region and in endocardial endothelial cells. And when we knock these out with mouse genetics, we lose the cardioprotective actions of drugs like liraglutide or semaglutide. So we can say, well, life is good. Now we understand this, until we make the mistake or decision to look at the human heart. In the human heart, as shown here by single-cell RNA-seq, the receptors are not predominantly endothelial. They're not predominantly endocardial, but they are in some cardiomyocytes in both the left and right ventricles. So we can't automatically assume that the data we generate in mice, which is exciting, is not necessarily indicative of what happens in humans. So still much more work needs to be done. We can ask the same questions about the reduction of atherosclerosis. GLP-1 receptor agonists do reduce atherosclerosis in the classical animal models, the ApoE knockouts, the LDL receptor knockouts, mice treated with a PCSK9 activating adenovirus. And we can say, well, how does this happen? Where are the vascular GLP-1 receptors? And in mouse aorta, they're predominantly in endothelial cells. So that's fine. I've shown you we can knock out the endothelial cell GLP-1 receptor, induce atherosclerosis in mice that now have basically almost no vascular GLP-1 receptors, and yet we still reduce experimental atherosclerosis when we treat the mice with drugs like semaglutide. So again, this shows us that we don't fully understand the mechanism. It's clearly not endothelial cells. It might be vascular smooth muscle cells or other components instructing the immune system. And this is something we're still actively working on. So what about the kidney? I've mentioned that SGLT2 inhibitors certainly are profoundly effective for reducing the risk of kidney disease in people with or without type 2 diabetes. If one activates the GLP-1 receptor, as we can see on the left-hand side, good things happen. We reduce experimental kidney injury, and in humans, we can reduce sodium excretion and albumin excretion. If we take away the GLP-1 receptor with mouse genetics, things get worse. There's more inflammation, more fibrosis, more kidney injury. And this is really intriguing, but it's hypothesis generating. So how does this happen? Well, there are some GLP-1 receptors in the kidney. They're in vascular smooth muscle cells in some afferent arterioles. And Novo Nordisk, I think to their credit, said, well, we really need to answer this question of whether or not GLP-1 will protect the kidney. So they initiated the FLOW trial in people with type 2 diabetes at risk of developing kidney disease because they started off with a reduced eGFR and increased albumin excretion. We don't yet have the full results of this trial, but about a month ago, this trial was stopped early because the Data Safety Monitoring Committee looked at the data and saw that semaglutide was clearly protecting the kidney. And we're quite interested in knowing, what components of the composite primary outcome contributed to the decision to stop the trial early. And we'll have to wait for 2024 to learn the details. There's also been innovation in drug delivery beyond simply extending twice a day to once a week. We now have an oral form of semaglutide. Quite amazing that we can give a peptide and it can withstand the very harsh environment of the gastrointestinal tract, and with an absorption enhancer snack, find its way through the stomach mucosa. And there's enough semaglutide that's absorbed to allow us to use this medicine in people. And if one looks at the clinical trial data in the phase 3 trial for oral semaglutide, you can see the data here. It's really as good or better than many of the once daily tablets that we use to treat people with type 2 diabetes. So this now provides another option for people living with type 2 diabetes if they're not big fans of injections. So is there any magic to giving oral semaglutide through the gut? Is there something happening in the portal vein that triggers a gut-brain axis mechanism that's helpful? It's hard to find the answer to that question from just looking at the clinical data. Here I've plotted the circulating levels of semaglutide, either given orally or by injection, and we can see hemoglobin A1C on the left and body weight reduction on the right. And this is thousands of people from the phase 3 clinical trials. And you can see that it's really all related to the circulating drug levels. Depending on how you get the drug in, you'll get the same reduction in A1C, the same reduction in body weight, independent of how you give the medicine. Now, oral semaglutide is pretty good, but it's not good as the higher dose injectable form of semaglutide that's used to treat people with obesity. And Novo Nordisk is doing research to improve the bioavailability. Here's some data that was presented at the American Diabetes Association in June. And we can see now with a higher dose of oral semaglutide and a different absorption enhancer, we're now getting to the 15% body weight range that's starting to be clearly impressive. And whether or not Novo Nordisk will ever be able to make enough oral semaglutide to allow this to be introduced into the marketplace, well, that remains to be seen because we are now living through a shortage of semaglutide. Where else might these GLP-1 drugs be useful? So there have been a few phase 2 trials, either with liraglutide or semaglutide, with biopsies done before or after administration of the drug in people with metabolic liver disease. And there's pretty clear evidence that there's a reduction of inflammation, but more uncertainty about whether or not fibrosis will be meaningfully reduced. And again, we're studying this in the lab, and most of us think that weight loss is a key driver of this benefit. It clears fat from the liver, it reduces inflammation. But if we focus in on the cells in the liver that express the GLP-1 receptor, and those are endothelial cells and gamma delta T cells, using our mouse genetic approaches, we find that these intrahepatic GLP-1 receptors are indeed important for the reduction of inflammation and fibrosis, and even the histological damage. And so, stay tuned. I think there's more to the story than just weight loss. Now, there are several phase 3 trials underway, one with a molecule from Eli Lilly called tirzepatide, and this trial with semaglutide is probably farthest along, and it will examine whether or not semaglutide can indeed be efficacious in people with metabolic liver disease, both for the reduction in the classical endpoints of inflammation and attenuation of fibrosis progression, but also the trial goes on for years to look at really important clinical endpoints, including, death and liver failure. So we'll have to wait, I think, 3 to 4 years to really get a sense of what the ESSENCE trial teaches us. So what's the excitement all about that we read every day with regard to GLP-1? And I think a lot of that surrounds weight loss. And again, Novo Nordisk deserves some credit in asking the question, if we use higher doses of liraglutide, higher than those approved for type 2 diabetes, can we develop a medicine to treat people living with obesity? And the answer we now know was yes. This is the results of the SCALE program for liraglutide, 3 milligrams once a day. And I look at this data, historically with interest. And to me, this is proof of the concept. In a few years, no one will be using very much liraglutide for the treatment of people with obesity. And the results are okay. We do get, 25, 30% of people with 5 to 10% weight loss, but they're not as good as people expect. And so I think this will be, something that we can say this proved the concept, but it wasn't the final definitive best molecule. And the results of this clinical trial program, the STEP program in people living with obesity treated with semaglutide 2.4 milligrams once a day, they've really caught people's attention. Now we're getting on average 14, 15, 17% weight loss. 40% of people are getting 20% weight loss. And as a result, we have a shortage of semaglutide. It's been approved in many countries at this dose, but you can't buy it in the pharmacy, which is a real supply-demand problem and terribly frustrating for people living with cardiometabolic disease. It's also been approved in many countries for adolescents, 13 to 18 years of age. And, this is really interesting because this is a terrible problem in many young people, but we don't have enough, I think, exposure, and we certainly don't have enough long-term data to really completely understand the long-term safety. And so we have to look at the individual in front of us and ask, what if I don't treat this individual, that they are at risk for developing diabetes and liver disease and premature cardiovascular disease, but if I do suggest intervention with something like semaglutide, what's going to happen to growth and pubertal development and their emotional development. So this is something that we need much more information on. And I think many more studies are indicated for us to understand the risk-benefit ratio in this young patient population. Tremendous excitement about tirzepatide, approved in the United States over a year ago. It's a GIP, GLP-1 receptor co-agonist, and it was very recently, a few weeks ago, made available in Canadian pharmacies, not in the form of a pen, because there's a pen shortage as well, but in the form of a vial that you can inject once a week, and hopefully the pens will come next year. And, we and others have studied GIP and GLP-1 for many years. I've summarized some of the actions here from an article that Rola Hamoud wrote in Nature Reviews a few months ago. And one could just simplistically say, well, GIP seems to be useful metabolically, so is GLP-1, add them together. Of course, one would have an additive benefit. And, does this explain the spectacular results we see for tirzepatide? I'm showing here the weight loss data in people with type 2 diabetes. This is better weight loss than we've ever seen before with a medicine used to treat people living with type 2 diabetes. And you can see SURPASS-2 is a head-to-head trial with semaglutide at the doses used for the treatment of type 2 diabetes, and tirzepatide is clearly more effective for inducing weight loss in this population. There's also a separate clinical trial program, the SURMOUNT program, for tirzepatide in people living with obesity with or without type 2 diabetes. And we've had several SURMOUNT trials report out now and be published. And the results are really impressive, 20% plus placebo-subtracted weight loss in most of these clinical trials, really offering a fantastic new opportunity to improve metabolic health. And we expect really any day now or any week now that the Food and Drug Administration, as well as other regulatory authorities, will improve tirzepatide as an indication and option for people living with obesity. So that's all in good. We should activate the GIP receptor, I guess, unless we look at this type of data, which is from Amgen. And Amgen has looked at the literature, which demonstrates that blocking the GIP receptor is also beneficial metabolically. And they have designed an antibody that blocks the GIP receptor and simultaneously activates the GLP-1 receptor. And here's the results from just a phase 1 trial with 3 injections. We have about 14.5% weight loss at the highest dose. But the most fascinating aspect of this data, look what happens from day 90 to 210, where there's no more injections. And after day 120, there's no more drug on board. But these people are still maintaining their body weight at their new lower achieved body weight. So very early days, very small number of people, but fascinating data. And this is now in a large phase 2 trial. Lots of progress in many different areas of GLP-1 therapeutic development. So here's the leading small molecule oral GLP-1 receptor agonist. It's called orforglipron. It was developed by Chugai and now licensed to Eli Lilly. And look at the data. After only 36 weeks, we're seeing almost 15% body weight reduction with the slope of the line still going down. So this is a very exciting innovation and is in a phase 3 program for both people with type 2 diabetes as well as people living with obesity. We also have innovation in the context of other multi-agonists. There's a lot of interest in glucagon GLP-1 receptor co-agonists. I think they will be particularly effective for people with metabolic liver disease, and the trials with NASH are underway. Here's the representative data we saw very recently at the ADA for survodutide. This was developed by Zealand Pharmaceuticals and now co-developed with Boehringer Ingelheim. And you can see again at the highest doses, even less than a year, we're starting to get 17 to 18% weight loss in the people who are on the drug. So this will be fascinating to see how the phase 3 results look like. And again, that will take a couple of years. There's also a triple agonist in phase 3 clinical trials. So activating the glucagon, GIP, and GLP-1 receptors simultaneously in one molecule. So this is retatrutide being developed by Eli Lilly. This might be the most powerful medicine yet developed based on these peptide hormones. And you can see on the left, the percent change in body weight. We're now getting more than 20% weight loss after only 48 weeks, and very impressive glucose control that's not shown here. So really fascinating innovation in the space coming very quickly. Well, does Novo Nordisk have an answer for these tremendous, exciting molecules from Eli Lilly? Maybe this is a combination in a single pen of 2 different molecules, a long-acting amylin agonist called cagrilintide, together with once-weekly semaglutide. And again, we can see here, after only 32 weeks, a very impressive 15% weight loss reported. And again, the slope of the line is still going down very sharply. So one would easily expect 20% and more weight loss. And this is being studied in 2 phase 3 programs, one for people living with type 2 diabetes, the other for people living with obesity. And there are multiple doses being studied here, both higher doses and lower doses. So again, it will take 1 to 2 years for us to get a glimpse of the results of the phase 3 program. Now, underlying this tremendous excitement in the new medical therapy of obesity is a big question that's always being asked. And it's asked very frequently by insurance companies and regulators who are reluctant to endorse reimbursement for weight loss medicines. And the conversation has often gone like this. Well, you lose some weight, your arthritis might be a little bit better, your sleep apnea might be a little bit better, you might feel better, but that's not really a big improvement to your health that really benefits the healthcare system. And so these drugs are really expensive and maybe we shouldn't reimburse them. And so we have had the results now of the SELECT trial, initially by press release and most recently presented at the American Heart Association and published. And what we now see for the first time with a medical therapy for the treatment of people living with obesity is a 20% reduction in heart attacks, strokes, and cardiovascular death. And these are tremendously important results now that prove, I think, to the community that obesity is a serious disease, which we've known, but not only that, we have a new opportunity to reduce the very serious and very expensive complications of obesity if we target the people most at risk with a medicine like semaglutide. So now I think the debate about reimbursement is going to get more interesting. We also, in August, saw the results of the STEP HFpEF trial. This is a trial in people with heart failure with preserved ejection fraction. It's quite common in people who are living with obesity. It does produce shortness of breath and limits physical activity. And you can see a summary of the results here. There was an increase in quality of life. There was weight loss. There was an increase in 6-minute walking time, a reduction in inflammation. And I suspect Novo Nordisk will be submitting this data to regulatory authorities. And for context, this data is really as good or better than any other medical therapy we have for this type of heart failure. So what is next? So there are lots of trials still underway for peripheral artery disease, for Parkinson's disease, for Alzheimer's disease. And, I've summarized here some of the rationale for why GLP-1 might be useful in the treatment of neurodegenerative disease. This is an extremely challenging indication to tackle, as we know. There are 2 phase 3 trials underway with oral semaglutide, the EVOKE and EVOKE Plus trial. Probably 2025, if we're lucky, is when we'll see the results of this trial. And there's also a phase 3 trial with exenatide once weekly underway for the treatment of people with Parkinson's disease. So we have innovation in the context of multiple new molecules being developed that have greater efficacy and perhaps more convenience. And we also have innovation in the area of new indications being studied that might broaden the applicability of these therapies beyond type 2 diabetes and beyond obesity, and perhaps not only to heart failure, but to diabetic kidney disease and liver disease, neurodegenerative disease. So we'll just have to wait and see how this unfolds. So it's been a pretty amazing scientific journey from discovery in the mid-1980s to the ongoing innovation that we're seeing as we've described here. And I think, as we all know, this strongly proves the value of investing in basic science, because one really could not have predicted these tremendous results that we're seeing decades later. So I'd like to thank the organizing community for the opportunity to discuss this with you. I'm sorry I can't be here. I have a previously scheduled commitment out of the country. These are the fantastic people in my lab today who are doing the experiments, and I'm sure there will be questions that my colleagues can answer.
Okay, thank you. And I will pass on your applause to Dr. Drucker when he returns.